Yeah. Welcome to this evening's teaching session for MECS and non-MECS practitioners. We're very fortunate to have Harpreet Muller with us today. She is an orthoptist. She's a specialist orthoptist, did her training at Sheffield, has since worked at Ipswich, and we've been fortunate to have her at Tommy's now for 6-7 years. Her speciality is, of course, orthoptics, but also works in the PEDS department and in the glaucoma department. I'm going to pass you over to Harpreet, if that's okay.
Hi, good evening, everyone. Thank you for that introduction, Bavina. So I'm Harpreet, a specialist orthoptist working at Guy's and St Thomas's, and today I'll be talking to you about binocular single vision, and hopefully I can just try and break it down for you guys. Okay, so we could just go to the next slide, please, Bavina. Thank you. So in this session, we'll aim to cover the principles of binocular single vision, common binocular problems that you might encounter in practice, how we would manage these, and when we want you to refer and not refer to us. Next slide, please.
Okay, hold on 1 second. Let's come here.
Thank you.
Okay.
So what actually is binocular single vision? So BSV is made up of 3 components. The first component is sensory fusion. So this is the ability for each eye to perceive an image as a single image. So we test this in the orthoptic clinic with Baglini glasses, which is the first image. And the second image is the Werf light test, which we use with red-green goggles. So this is a response of a patient with binocular single vision. If a patient sees 5 lights, that would indicate diplopia, or if they see 3 lights, that could indicate suppression. The second grade of binocular single vision is motor fusion. So this is the ability to maintain a single image during vergence movements. So this could be convergence or divergence. So in young children, we test this with a prism reflex test. So we introduce a prism whilst the child is accommodating on a target, and we're looking to see if the prism with the eye that hasn't got the prism over it goes out and comes back inwards. And for older children and adults, we use the prism bars to measure the fusion range. And the final grade of 3D vision, binocular vision is stereopsis. So this is your 3D vision. So the ability to perceive depth. So this is being able to negotiate curbs and stairs. So we tested this in the clinic with the Frisbee stereo test. We also use the Werf fly and the Lang picture for smaller children or younger children. Thank you. The next slide, please. So what happens if there is no binocular single vision? So if a binocular abnormality occurs during the, well, we say when vision is still very much developing, so up until the age of 9, when there's still visual plasticity in the visual system, a child will develop suppression. So this is a response to diplopia. So they will ignore the image from the deviating eye. So these children tend to be asymptomatic and won't generally complain of diplopia to you. If diplopia or a binocular problem occurs after the visual development age, diplopia will be appreciated. So if the visual axes are not aligned, they will not be able to suppress the second image. So we tend to get adults that complain of diplopia when we see them in the clinic. You might also encounter adults that have a history of childhood strabismus and therefore they won't complain of diplopia. But they might come into you saying, I'm more aware of my squint, or I think it's getting worse. So these are cases just to be aware of. I actually saw a case not so long ago in the orthoptic clinic where a patient, they're about 40 years old, they had a history of patching, 2 squint surgeries, and they'd gone to their optometrist complaining of their esotropia increasing in size. So I was surprised to see when I looked at the glasses that they had Fresnel's prisms incorporated into their glasses. And I asked them, have you ever had any double vision? And they said they'd never had any double vision. So it was just something I wanted to highlight because we always give prisms to try and restore binocular single vision, but this patient didn't have the ability for that due to their history of patching and surgery. So it's just something to bear in mind and to really take a careful history that will guide you for management. Next slide, please. So just a few images, they're not there to scare you. I hope they'll just break down and help you to kind of comprehend what happens when we have got someone with binocular single vision. So the first diagram, when the patient is looking at the object, which is indicated by the O, we can see that both foveas are being stimulated. So the image is falling on corresponding retinal points. So if we go to the second image, we've got a patient here with a right esotropia. So the left eye is fixing and it's being stimulated when it looks at the object, but the right eye is deviating, and you can see that the object is actually hitting a part of the retina that is not corresponding with the fovea, hence why diplopia occurs in adults generally, and the same for the second image as well, just indicating the same thing in a patient with an exotropia. Next slide, please. So what are the common binocular vision problems that you might encounter in practice? So I'm going to start with children first. So this could be a squint. So parents may come in complaining of their child squinting intermittently. So they might mention it when they are focusing. So if they're looking at their phone or when they're reading, or sometimes in the distance, so when they're watching TV, or it could be in bright sunlight. So we as orthoptists are concerned if we see a child that's born with a constant exotropia or a sudden onset squint at any point in childhood, as this could indicate pathology. Any patient with an isometropia or dense amblyopia in one eye, this could also cause fusion problems and binocular abnormalities. And any ocular motility problem, so this could be a muscle imbalance or A&V patterns. So I'm just going to take you down to the images here. So the first child, if you have a look at the corneal reflections, so in the right eye, the corneal reflection is falling centrally. But if you take a look at the left eye, the corneal reflection is temporal. So this indicates that the left eye is turning inwards, which means that there's an esotropia there. And if we look at the second image, it's not quite as easy to notice. I think this child is possibly slightly dilated, but when you look at the corneal reflection in the left eye, it is slightly nasal, and that indicates an exotropia. Next slide, please. So what are the common BSV problems that you might encounter with adults in practice? So adults might come in complaining of a gradual onset of diplopia. So this could be over the course of several months or even years. This tends to be a decompensating heterophoria, but occasionally we can see some more sinister causes of this. So we have seen a few cases of schwannomas and slow growing tumours. So we always want to investigate these patients if they're not improving in terms of the symptoms. So you might see sudden onset diplopia. So this could be your nerve palsies or trauma cases. So any of these patients, we want you to refer urgently to eye casualty or to A&E if it's out of hours, as they would need further investigation. You might see some adults that have childhood squints and they are noticing further increase of their squint, so they want to be referred for further management of the squint. And again, presence of A&V patterns or ocular motility problems, and patients with this in the adult groups tend to be symptomatic and will complain of this in terms of diplopia. Okay, and the next slide, please. So managing children. So we always want to correct any refractive error. So particularly if you've got children that are hypermetropic with esotropias, because sometimes these could actually be fully accommodative esotropias if you give the full refractive error. So we want to treat any amblyopia, so that could be with patching or atropine. Sometimes we use exercises if there's fusion problems or convergence problems. And here at Grindstone St Thomas's, with our intermittent exotropias, we have often used minus lenses to induce accommodative convergence to aid control of the exotropia. And as a final stop or more long-term measure, squint surgery can be considered in some children as well. Next slide, please. So how do we manage adults? So adults complaining of diplopia, we would give them prisms. We always like to give them Fresnel prisms first. And the reason for this, as you know, prisms are quite costly to incorporate into glasses, and we want to make sure that things are stable. So we generally at St Thomas's have a rule: if the patient has been stable in terms of the measurements for about 6 months, we would then consider putting the prisms into the glasses. But up until that point, we're happy to keep them Fresnels just in case things are evolving. We sometimes see some patients that have very complex ocular motility problems. So they could have multiple, like horizontal, vertical, or torsional diplopia. So it can sometimes make it very difficult to join the diplopia with prisms. So occasionally we have to use an eye patch or blend them over the glasses or an occlusive contact lens. Some patients we perform Botox. So I have a video of this in the next slide, but I'll just give you a bit of background. So we use botulinum toxin and we inject the muscle that's overacting. So for example, if you've got a patient with an esotropia, we would inject the medial rectus, and this would paralyze the medial rectus and help the eyes to take up a straighter position. We like to do this in patients, and particularly the ones that are considering squint surgery. And if we're looking to see if they've got potential for BSV, so we can see how they would respond to squint surgery and whether we want to undercorrect or overcorrect our surgery. As I mentioned, squint surgery, and again, we can also use exercises in adults as well, so particularly stereograms and the dot card and pentanose for convergence weaknesses. Okay, and next slide, please. So I just wanted to show you a video of Botox. So Vina, are you able to allow me to share my screen, please? Thank you. Can you hear that?
We can't see it either at the moment.
Your screen's not sharing yet. Do you want to unshare and reshare it?
Oh, bear with me.
Does it look like a whooshy sort of noise?
Oh.
Yeah, we're good. We're good.
I'm not sure if there's sound though, Harpreet.
Oh, is it not? Okay, no worries. I'm going to talk over it. So
I can hear it, but I think you've got to know what to hear. It's a little sort of whoosh noise from the readings and
yeah,
the electrodes are in place.
There's also someone talking over it, explaining what they're doing, but I'm happy to do that if we're struggling with the sound. So basically, they're having the Botox injection into the lateral rectus. So we use an EMG machine and we're listening out for the signals. So as Miss Obi said, you get like a whooshing sort of sound, and that's when you know that you're hitting the muscle. So they keep the needle there for about 30 seconds and no longer than that, because that's when we can risk the Botox leaking into the other extraocular muscles. So once that's done, we remove the needle, and then we'll review the patient in the orthoptic clinic about 2 weeks afterwards, just to check that they've had no undesirable side effects from that. Great, thank you. So I'll just ask you to share your screen again, please, Vina.
Sure. Give me one moment. Can you see your slide again?
I do, thank you so much. Okay, so squint surgery in adults. So we can recess. So this is to move back and to weaken an extraocular muscle, or we can resect. So this is to move forward and strengthen an extraocular muscle to reach the desired eye position. So with adults and some older, more cooperative children, we can use adjustable sutures. So after the patient has had the squint surgery, and they've come around from their general anaesthetic, we'd go and assess them in the ward, and we'd check the eye position by doing a prism cover test and checking for diplopia. If they are diplopic or they're not in the desired eye alignment, we can actually move the eye position by adjusting the adjustable sutures until they are asymptomatic or the eyes are looking straighter, and then we can tie them off there and then. Next slide, please. So when should you refer? So we always want to see children with any suspected amblyopia or visual acuity that's not improving following refractive adaptation if they need glasses, as this might warrant further investigation. Any child with strabismus, any extraocular muscle imbalance, or head postures. So I appreciate this isn't always easy to pick up in children, but we'd always rather that you refer so we can have a look. We do occasionally get a few referrals from the optometrists or sometimes actually coming in from the GP. So any child that has got a swollen, painful red eye with blurred or double vision, and if they're not feeling very well, we always want to rule out orbital cellulitis so we can start treatment quickly if that is the case. So I've just got a picture here of a child. Does anyone want to have a guess what is going on with their eyes here? Feel free to shout out.
I'm just going to remind people that you may be on mute. So if you're shouting out, we can't hear you unless you unmute yourself.
Is it Dwayne's?
Not quite a Dwayne's. Or if you're not sure of what the condition is, just describe what you can see.
Someone has put Browns in
Yes, exactly. Got it in one. So this is a limitation of elevation in adduction. So as the child looks up and to their left, the right eye is not fully moving up in an adduction. So this is a developmental thing, and we don't tend to do much for it, but they do require monitoring in the orthoptic clinic. Next slide, please. Okay, so when to refer when it comes to adults? So we want to see anyone with sudden onset diplopia or trauma. These need to be referred urgently, as they might need, well, they will need ophthalmological investigation as well as orthoptic assessment. Anyone with gradual onset diplopia, any long-standing squints, so and they might not necessarily have diplopia because they've got a childhood history of the squint, and they might want to have interventions such as surgery or Botox. We also want to see any extraocular muscle imbalance, such as an inferior rectus underaction. So the reason why I've chosen to speak about inferior rectus underaction is that it often warrants other systemic workup. So having an inferior rectus weakness can actually be a sign of an autoimmune condition, such as thyroid eye disease or myasthenia. So I'm just going to take you down to the first image here. Does anyone want to shout out what they can see about this patient?
Again, you might be on mute. So if you're saying something, we can't hear you.
Proptosis?
Yes, yep. Anything else?
Someone's put TD in the...
Thyroid eye disease.
Yeah, what kind of things are you seeing? So we've got the proptosis. Is there anything about the actual eyes themselves that you can see that looks a bit suspicious?
So somebody's put left eye hyper.
Perfect. Yeah, exactly that.
Red eyes.
Yes, exactly. So they've got chemosis left greater than right. What about not so much the eyes now? So if you're looking at the periorbital area, anything going on there?
Looks a bit swollen.
Yes, exactly.
Lid,
so, yep, sorry.
Frontalis overaction on the right.
Yep, so lid retraction, exactly. Yep. Yeah, I think we've got everything there actually. So this is quite a typical case of thyroid eye disease. So proptosis and periorbital edema. So what happens is the contents of the orbit can start to expand due to all the fibrosis of the extraocular muscles. And these patients can get very limited eye movements, and that can also give rise to diplopia. So an inferior rectus underaction can also be a sign of myasthenia gravis. So just going to take you over to the next picture. Anyone want to shout out what they can see about this patient?
Ptosis in the right eye.
Yep, it's actually bilateral, but it's more noticeable in the right compared to the left. But yeah, certainly is a ptosis. It's a bit tricky to see from the images, but if you have a look at the eye position, do you think that there's any deviation there?
Is there a small sort of a hypo in the right eye?
Yeah, there is. Well done. So there's a right hypo and a right exotropia, but I appreciate it's not the best image, but myasthenia can be really variable, quite tricky to diagnose at first, because these patients can come in and they might look like a certain thing on one day and have a completely different clinical appearance on the other day. So we're guided by a fatigable ptosis and variability in clinical signs and symptoms. So just going back to when we should refer, so anyone with a ptosis, headache, diplopia, and pupil involvement, think a third nerve palsy. So again, that warrants urgent investigation. And if you're not sure about any binocular abnormality, we'd always rather that you referred up to us so we could have a look. Next slide, please. So just a bit of feedback on a referral that we saw. So generally the quality of the referrals that we get in the orthoptic clinic are really good. We see a lot of patients that we think, yes, you definitely need to come in and see us. But there's just one that I had the other week. So she was a 38-year-old patient referred from the optometrist with blurred vision. So she'd never complained of any double vision. So she was given a plus 250 ad veneer, which is quite strong considering she's fairly young. So she was noted to have dry eye symptoms at the opticians, and I think this was the main concern for her when she did see her optometrist. So ideally, this patient would have been reassessed by the optometrist after treating the dry eye symptoms, and also she should have had a convergence checked. So she wasn't diplopic, but she did have reduced convergence, and her accommodation was normal. But we found by reducing her near ad that her convergence was normal. So had this been checked at the optometrist, it would have saved up a referral up to the hospital. But again, like I say, if you're not sure, we'd always rather that you refer to us, and we're happy to look. Okay, next slide, please. So what happens after patients are referred to us? So these are our guidelines at Guy's and St Thomas's. So any patient over the age of 60 with a single cranial nerve palsy, excluding a third, with known diabetes or hypertension, we don't tend to further investigate. We would advise them on their risk factors, and we would inform the GP just to help to maximise controlling these. Next slide, please. So we want to investigate anyone with a third, particularly if it's a painful and with pupil involvement. If there's a patient over 60 with no known microvascular factors, we want to check for ESR, diabetes, blood pressure, and blood lipids. If there are patients that are under this age of 60 and they have gradual onset, or they have a history that doesn't really fit in with their clinical picture, or they present with multiple cranial nerve palsies, or they don't have any risk factors, or they have a nerve palsy and it's not recovering after 12 weeks, we'd always want to further investigate that. So that could be further bloods and further imaging. Next slide, please. Okay, so what do we want in our referrals? So we want to know which speciality you're referring to. So that would be ocular motility or the strabismus clinic. We want a detailed history, including the signs and symptoms and the onset of these, and what the patient's concerned about. Is it the double vision, or is it the appearance of their eyes? We want the visual acuity, refraction, and the details of the prisms if these are incorporated, because it saves us a lot of time when we're investigating them in the orthoptic clinic. And we have had a few referrals with details of this missing. If there's any suspected extraocular muscle imbalance, details of this as well, and how soon you want the patient to be seen, so whether it's a routine or an urgent referral. Next slide, please. Okay, so Vivian, if you wouldn't mind just sharing, allow me to share screens, please. Okay, so I'm going to play this video, and I just want to see if you're able to pick up on what's going on here with the eye movements. Okay, does anyone want to shout out what they could see there? Yep. concomitant right hypertropia. Yeah, exactly. And could you notice when they were looking in a certain position of gaze if that got worse in one direction compared to another direction? Yeah, exactly. So when they look over to the left, and might not have been so easy to see, but when we were getting the patient to tilt their head to either side, we're doing the Bielczowski head tilt test. So when that patient tilted to the right, their vertical deviation increased, which is positive for a fourth nerve palsy. Okay, so I just want to show you another video. Okay.
I stopped your screen share, so
Oh,
you might have to
sorry. Yeah.
stop.
Thanks.
It's not sharing at the minute.
Can you see that now?
Yeah, it's just started. Yeah.
Oh, yeah, lovely. Feel free to shout out. What did you notice with that patient?
So in the chat, we have 6th.
Yeah,
right,
exactly.
6th.
Yeah. So the actually that was the left eye. Sorry. So yeah, left. So the left eye is not fully abducting. So in the sixth nerve palsy, they often complain of double vision. That's worse for the distance compared to up close, and they have the loss or limited abduction. Thank you. If we could just jump back to the PowerPoint, please, Bavina.
Sure, of course. Are we back on the PowerPoint?
We are, thank you.
Change to the
Oh, sorry, we need to share screens with me again. I have another video that I forgot about.
Okay, one moment.
Thank you. Okay, so what would you do if you saw this in your clinic?
I can't see it yet.
Oh, sorry.
Yeah.
There you go. Thank you.
Okay. So first of all, what did you notice with her eye movements?
I'm going to stop that screen share now.
Oh yeah, thanks. Was there anything untoward or abnormal about her eye movements that you could see?
So in the chat, there's bilateral loss of adduction.
Yes, exactly. Yeah. Anything else?
Retraction question mark?
Not quite retraction. More related to eye movement. So yep, certainly the bilateral loss of adduction of either eye. But there was something odd when she was looking over to each side. Yes, exactly. Nystagmus. Yep. So she had abducting nystagmus. So this is a bilateral intranuclear ophthalmoplegia. So it's quite rare. But what would you do if you saw it in your practice?
Everyone's looking blankly. Urgent
Perfect.
referral to 8.
Yes, that's what I'm looking for. Exactly. I hope no one sits on that and thinks, okay, let's review again in like 6 months. It would be an urgent referral. So again, like I say, it's rare, but anything that doesn't make sense or looks a bit strange, and particularly patients that are complaining of symptoms such as oscillopsia or generally not feeling well in double vision, just send them up to HES urgently. Thank you. If we can just go back to the slides, please, Bavina.
Yes. Right.
Thank you. So I've just got a few cases. So we've got a 66-year-old male comes into your practice. So general health, has hypertension, takes medication for this. He has a history of double vision when reading. It's been going on for a few months now, and it disappears when closing one eye. So his main issue is blurred vision, headache when he's reading. So vision 0.16, 0.1. Cover test, he's got a exophoria that's poorly controlled for near, and in the distance, he's got a well-controlled exophoria. Nothing significant on ocular movements. His convergence is binocular to 16 centimeters, and then his right eye diverges and he appreciates diplopia. So his fusion range is 4 diopters base out to 12 diopters base in. And just for context, a normal fusion range is 20 diopters base out to 10 diopters base in. And his stereopsis is a little reduced. What could the diagnosis be here?
I can't see the chat anymore.
Oh.
So.
Or feel free to shout out.
Remember, you're on mute. You might have to unmute yourself. I think, Harpreet, if we could just have an idea of how you would think about this case. What
Convergence insufficiency we've got.
Yes. Yep.
Convergence insufficiency is the answer we're given, but it'd be useful to know how would you think about this case? What are your thought processes?
So for us, when we see this patient, again, history is key. So when is the patient noticing a problem? So they're noticing it when they're reading. Again, the onset. So it's a bit strange that this patient's 66 and they've started to develop convergence problems at this stage. So we're really guided by the convergence, ocular movements, and also looking at the the binocular vision tests as well. So we can see that the fusion's a bit reduced too. So our approach would be, again, trying to treat the convergence weakness and just really listening to the patient and what their main concerns are, as well as ruling out other issues by doing a full assessment. And I appreciate you don't always have time to do that in practice, but a cover test and ocular movements does go a long way.
There was a question in the chat saying, what's PCT? I know the answer, but I'll let you answer that one.
Sure, yeah, sorry. Yeah, there's a lot of orthoptic abbreviations on here. So PCT, that is a prism cover test. Have I written that on this slide?
No.
Oh, okay, fine.
I think they're asking what the PCT of this patient is.
Oh, fine. Okay. PCT, fine.
Sorry.
I should have put that. You're right. So they were greater for near. So let's say, for example, they're 20 diopters base in for near and 18 diopters for the distance.
Sorry, I misread the question. I thought someone was asking what it translates to.
Oh, no worries. That's fine. Should we go to the next slide? Thank you. So you have a 53-year-old female. She's in good general health, no medications, but she presents to your practice with sudden onset, vertical and horizontal double vision. This occurred in the last 2 days. She's got a really painful headache and a dilated left pupil and left ptosis. What would you do with this?
So A&E, emergency refer.
Yeah, exactly that. Yep. So refer urgently.
People are saying it's urgent. Yeah.
Yeah, perfect. Yeah, Yeah, it's suspicious that she's in good health and she's presented with this. So I'm just going to show you on the second image. This is a Hess chart. So we often use this in the orthoptic clinic to plot eye movements. So in a patient that is orthophoric and has no deviation of the eyes, you'd expect the black sort of lines to be a square shape. So on the left side, so the first square, we can see that this is quite squashed. So basically that left eye is not elevating and it's also having some problems depressing. So that indicates that's the affected eye and those are the muscles that are affected. So it's quite nice for us to document recovery when we do see someone with a palsy or a restriction. We can just go to the next slide, please. So we've got a nice image, but when this patient was scanned, so they were found to have a posterior communicating artery aneurysm, which they urgently went to theatre to have clipped. Next slide, please. So you see a 5-year-old child that comes into practice. Parents have noticed that their child is closing one eye, particularly in bright sunlight. So the visual acuity is 0.2 right and left on crowded logma. So cover test, they have a fairly controlled exophoria for near, and in the distance they've got a right exotropia, as you can see in the images just across to the right there. Ocular movements, they have a slight V pattern, and we cyclorefract them in the practice and we find them to have the below refraction. Next slide, please. So you'd want to treat any refractive error, and you'd also want to refer them on to the HES for an opinion on the squint. So just to note here, we do see a lot of kids that have intermittent exos, and just by giving the minus lenses can help them control their eyes a lot better. But even with the with this, we'd still want any referral for an intermittent squint, just so they could be under the books for hospital eye services in case they eventually need to go on to have surgery should they further decompensate. Next slide, please. Okay, so please feel free to put in the chat or shout out, but what do you notice about this child?
Head turn.
Head position.
Exactly. Any ideas or differentials as to why a child might have a head turn?
Sixth question mark, amblyopia. Dwayne's, sorry, I'm just reading out the chats.
That's great, thank you.
Left exotropia, question mark.
Perfect. Yep, right,
Right aniso, septum, nose. No, I read that wrong order. Right aniso minus nose equals septum.
Great, yep, so you've hit all the big ones there. So nystagmus, Duane syndrome, sometimes a squint, so sometimes a child might turn or tilt to the better seeing eye. So we often see that. Sometimes it can be habitual and sometimes there can be non-ocular causes to head postures. So what would be your next steps if you did see this child in practice?
Straighten to primary position and do cover test.
Yeah, perfect, exactly. You want to see if the eye position is changing at all with and without the head posture. Yep. Anything else?
Ocular movements.
Yeah, absolutely. If there's any nystagmus or extraocular muscle imbalance, perfect. That's great, lovely. And the next slide, please.
Cyclo as well, just refract, obviously.
Yeah, absolutely. And you want to look at the visual acuity uniocularly as well, just to rule out any amblyopia.
Moving to the next slide.
Yes,
there we go.
please. So I have another video, Bavine, if you wouldn't mind just sharing.
Give me one moment. There you go.
Thank you so much.
It's yours.
Okay. So just have a careful look at his eye movements. Did everyone catch that?
I think so. Nobody has said no.
Okay, good. Anyone want to shout out what they think it might be?
Dwayne's?
Yeah, exactly. Yeah. So the right eye was not fully adducting as the child was looking over to right gaze. I don't know if you can notice, again, the picture was quite blurry, but the palpable fissures were widening as he was looking in the direction of limitation. And when he was looking over to the left-hand side, the palpable fissures were narrowing. So that is a differential diagnosis from a 6th nerve palsy when it comes to limitation of abduction. Okay, next slide, please. Okay, so I hope after this session you feel a bit more confident of when to refer to us, and hopefully you feel a bit more aware of the details that we want on the referrals, and hopefully you have more of an understanding of what happens after you refer to the hospital eye services. Next slide, please. Are there any questions for me?
Right. Actually, I'm going to cheat and add 2 questions at the beginning, just I think it's useful for this information to be shared out to everyone, and then I'll let everyone else give a chance to type their questions in the chat if they want to chat, or they're more than welcome to take themselves off mute and ask the questions. So my 2 questions for you, Harpreet. Firstly, one of the slides you mentioned the fact that it's worthwhile when you refer after a length of refraction adaptation. How long do you expect how long should we wait as optometrists before we refer them onto you, a child onto you? The reduced VA, we refract them, we give them glasses. How long would we wait before we send them to you?
So there's actually a paper from PEDIG that we also use in our department, but we'd be happy for optometrists to wait 18 to 22 weeks, because PEDIG have established that that's the amount of time that you need to allow for full refractive adaptation. So if there's good compliance and no other concerns, they're wearing the glasses, the vision's still not coming up after that period of 18 to 22 weeks, and send up our way.
Thank you. And then the second question was just so that our optometrists are aware of the difference between ocular motility clinic and a squint clinic. Like,
sure.
So if we have a patient, how do we decide which is the right clinic to be sending this patient to?
Great question. So actually for us, we are split into adults and children. So hopefully that simplifies things. So we would see someone with an ocular motility problem and or a squint. So basically you could put either and they would get seen in the right clinic.
Right. From a triaging point of view, just so that the participants are aware, for a child, we have the option of both ocular motility and squint, and for an adult we have the option of both ocular motility and squint.
Yeah, exactly.
And a child, a squint clinic will also have orthoptist, optometrist and an ophthalmologist on site. A squint clinic for an adult may or may not have all participants. Is that correct?
Sorry,
so an adult. Yeah. So an adult ocular motility clinic may not have ophthalmology involved as well.
Oh, sorry.
Just have.
So we do.
Oh, you do?
We do, yep. So any new referral would be seen by the orthoptist and the ophthalmologist. And that's the same for both children and adults when it comes to ocular motility issues. So the only difference we have might be kind of like the vision clinics, where children might be seen by orthoptists and optometrists alone, but for any ocular motility or squint issues, they would see the orthoptist and the doctor.
Okay. One other question is more a case of the albinism effects on binocular vision. You can shoot your for that question.
So, good question. So basically in ocular albinism, what happens is there is misrouting at the chiasm of the optic nerve fibers. So it's been shown that 90% of patients that have chiasmal misrouting will end up with binocular problems and or nystagmus. So it's really quite a high percentage. So if they have that, then it's most likely that they will have ocular albinism, and as well as obviously the hypopigmentation and the light sensitivity as well.
Lovely. And then there's a question about amblyopia. When would atropine penalization be preferred to occlusion therapy as a treatment?
So it's actually been lots of papers, and there's lots of centres in the UK that offer atropine as a first-line treatment as well. But I know a lot of people are a little bit hesitant to try atropine first because there can be lots of side effects attached to it. So so we would offer it equally, but generally, actually no, that said, at St Thomas's, we tend to patch first. If there's compliance issues, then that's when we would try with atropine. However, if there's children with very, very dense amblyopia and the atropine isn't enough to blur the vision in the good eye with penalization as well, they wouldn't be a candidate for it. Then we'd have to try and push with patching treatment.
Lovely. I'm just going to add 2 more questions, then I'm keen for us to move over to the next phase of our evening, if that's okay. So one question is, when would you consider surgery or Botox for adults?
Sure. So Botox or surgery, we'd usually consider when the patient has been stable. So sometimes we see them at the initial appointment, and then we'll wait another 3 to 4 months to repeat our prism cover test measurements to see if there's been any change. If there's not been any change, then we can go ahead with surgery. But a lot of it does depend on the cases that we see as well. So for example, if you've got someone with a long-standing nerve palsy, you'd want to wait for probably quite some time, about 6+ months, just to ensure that there's no change to the nerve function before we go in and do the surgery. And Botox, because we're a bit more kind of willing to perform Botox as it is a temporary thing, because a botulinum toxin does wear off after about 3 to 4 months. So we, like I said before, we can perform this before we do the squint surgery, as it can give us a nice predictor of how that patient's going to respond to squint surgery.
I'm going to do one more question, and then if there's any more questions in the chat, then what I will try and do is aim to get those answers out to everyone after I've had a word with Harpreet, if that's okay with you, Harpreet?
Yeah, cool.
So one last question, does the decision to refer after 18 to 20 weeks depend on age? If a child is aged 8 years, for example, should they be referred sooner?
Good question. Yes. So to use your discretion, if you think that there's a child with suspected amblyopia and they are reaching the end of their visual maturation period, then do send them a bit sooner so we can see them. And if we need to commence occlusion, or atropine, at least we can start that sooner rather than later, and they have more of a fighting chance to try and improve the amblyopia.
Okay. Well, thank you very much. Sure did learn a lot, and thank you for answering all these questions. There are more in the chat, I have to say, so it may be that I need to get those answers out to everybody at some stage. I'm just going to stop recording, if I may.